I am delighted to introduce our speakers for today's session. Bronwyn Rideout. Bronwyn is a registered midwife based in New Zealand and currently a PhD candidate at the Te Waka Victoria University of Wellington. And she brings both academic insights and hands-on experience on her work, especially in the area of perinatal care. And together with her colleague, Amy Taylor, Bronwyn co-hosts the Neurobird podcast, which explore the intersections of neurodivergent and the childbearing experience. And you can check it out at neurobirdpodcast.com. Wait, I will share. Yeah, Bronwyn, thank you. You share the link. You can click the link that Bronwyn shared, guys, and you can check it out. Bronwyn has also facilitated a range of impactful workshop and studies days, focusing on how we can better support neurodivergent individuals in perinatal settings, a topic that's both timely and deeply important, right? And in this session, Bronwyn will be presenting on the childbearing experiences of autistic person in Aotearoa, New Zealand, opportunities and challenges of continuity of care. Wow, this is a powerful exploration of how we can create more inclusive and supportive maternity care system, right? And Brownin, we are so grateful to have you with us today. And yeah, this time is yours.
All righty. Now, can I? We're going a bit too fast. That's perfect. Okay, well, kia ora, everyone. Thank you for coming to my presentation. I won't really improve too much upon Zalfa's lovely words, but yes, kia ora, koto, ko Bronwyn Rideout, toko enoa. And I guess the only thing I'll add to everything is that I'm actually autistic myself. Like many females or persons who are assigned female at birth, I was diagnosed well into adulthood, particularly after I finished my midwifery training. So my diagnosis journey was very much part of my midwifery training as well. And that kind of became the genesis of this whole, this multi-year journey to do this PhD. So yes, what I'm doing is just actually sharing a selection of findings from my PhD research into the childbearing experiences of autistic people in Aotearoa. And for those who may not be familiar, just to maybe say something in brief about New Zealand midwifery, it's a very unique midwifery-led system that promises continuity of care, informed choice, and partnership. However, the dearth of local quantitative data and cohort data about the autistic population means that we don't really know if our maternity or perinatal care providers are actually able to meet the needs of this community. So my research question was quite simple. What is the childbearing experiences of autistic people in Aotearoa? And then what kind of processes do they use to navigate the transition from pregnancy to parenthood? So the autistic community has been quite vocal about their priorities and aspirations for research, and they're championing research that improves autistic health and well-being and outcomes as determined priorities by the autistic community, as well as challenging how autistic people have so far been able to participate in research that impacts them. So, really advocating for autistic input and leadership in design and just the absolute whole research process. So I ended up selecting a constructivist grounded theory methodology because it's inclusive, it's inductive, iterative, and that approach to data means that not only is the theory grounded in the words and the data of my participants, but also as an insider researcher, it allows me to go into this project with my significant level of pre-knowledge. And, it also meant I was able to engage with my participants authentically because they would be expecting me to be an insider autistic researcher. And that's something that particularly other subtypes of grounded theory don't quite allow. So the chief methods of data collection ended up being audio and written interviews conducted either by Zoom or by email as per participant preference, and that made the data collection inclusive. Initial spoken interviews were about 40 minutes to 2.5 hours long, so a lot of transcribing work here. And then when I did follow-up interviews with about 13 of the participants, those interviews, particularly the spoken ones, were about 30 minutes to 1.5 hours. I was able to recruit 15 participants who were either formally diagnosed with autism or self-identified as autistic, who birthed in New Zealand between 2012 and 2020. And I included the self-identified participants, and that was due to both following international precedents, international research precedents, I should say, community preference, and it also acknowledges that, the financial and resourcing obstacles that so many autistic people need to face in adulthood in order to get that diagnosis should not be a barrier to their participation in research in the first place. So just a bit of a summary of who these participants were. 13 participants were diagnosed about 4 to 6 years after the birth of their first child. While 8 were formally diagnosed and 2 were self-identified, 5 received what I call a semi-formal diagnosis, and that's a term I kind of use to describe any confirmation of autism that participants had received from an appropriately qualified psychologist or psychiatrist, but they had not gone through the entire process or had paid to complete the assessment process. So there has been professional involvement and professional insight into this, but it's not official yet. Participants represented a range of birth experiences from home birth to cesarean section by maternal choice. And likewise, they represented a range of experiences across the family planning continuum. So that includes abortion, miscarriage, IVF or fertility treatments, both as a recipient of an egg or an embryo or as an egg donor themselves. And also adoption was on the table for some of these participants as well. Despite the low number of home birth or primary birth numbers, that actually is not reflective of the number of participants who actually did want primary center births or home births. Particularly for home birth, the number is almost double. About nine births is where the home was wanted as an ideal setting. And then finally, of the 24 children born to participants, 12 have since been diagnosed with autism or another neurodivergent condition. An additional 12 are still seeking a diagnosis. And then there are 8 children who are suspected, but their parents aren't really seeking an assessment presently. Again, either due to the cost, due to the age of the child being too young for sort of normal, publicly funded assessment services. And in one case for a family that's now in Australia, to get their child diagnosed would absolutely mean they could not immigrate to Australia. So they've had to put those plans on hold. For the non-New Zealanders, I just did want to take a couple of slides to explain a bit about the setting of where my research is. So we have in New Zealand about 57,000 to 58,000 births per year, with about 95% of New Zealanders receiving community-based continuity of care from a midwife. In terms of birth setting, our home birth rate is about 4%. Primary units are the setting of about 8% of births, but the remainder do occur in secondary or tertiary units, which are placed within secondary or tertiary hospitals. In terms of our New Zealand statistics, we actually don't know how many autistics we have in New Zealand, diagnosed or otherwise. In New Zealand, basically, we borrow our population numbers from UK, so we just kind of extrapolate from that. And for many years, we've been saying, oh, it's 1 to 2%, it's between 45 to 90%. But recently, we've upped that up to 3%, so now we're saying about 160,000. And that's comparable in a sense to ADHD numbers. They're saying that about 5% of people in New Zealand have ADHD, and that's about 28,000. And because we have that cross-correlation, that cross-co-occurring connection between ADHD and autism, likely our autism numbers are still even higher. We have a lack of a formal diagnostic pathway for adults. So getting a diagnosis just ends up being costly because so many adults have to go through the private pathway. So they're paying $2,000, $3,000 on average. And, on top of that, being able to get a psychologist who is both experienced and not only diagnosing autism in adults, but also specifically diagnosing autism in women is very hard to find, and you get booked out really quickly and have waiting lists of like months to years long. So that's kind of a financial burden that either the family takes on in order for, family members to go out of town to get a diagnosis, or they actually end up going without. And that can have significant consequences if you are lacking your occupational or other support services or access to those support services. In terms of how the sex ratio is going for autism diagnosis, amongst some of the cohort studies that have been done on autistic children ages 0 to 24, we are still seeing similar ratios as we see in international studies, which is a 1 to 4 female to male diagnosis ratio. But in adulthood, particularly in our smaller qualitative studies, we do see more of a skew towards more autistic female participants in those studies than we do see autistic males. And then finally, midwifery and even obstetric care is overlooked. We do have an autism guideline. The 3rd edition was published in 2022, and that kind of describes how to best support autistic people in New Zealand across their lifespan, so to speak. As I said, midwives and obstetricians and obstetrical care are missing. They're completely overlooked. And we're not included in the list of practitioners who do require access to specialist education, knowledge, and skills to be able to work with autistic people. So this gap ends up being quite noticeable, particularly in this guide, because the discussion jumps from first saying that, oh, autistics could marry, they could have relationships, and then completely jumps to all the welfare concerns that they will have for children who are raised by autistic caregivers. That includes the suggestions that, counselors need specialist training to support children who have autistic parents. So not a very neuro-affirming guideline. And of course, in between that, there's no discussion of autistic pregnancy. So yeah, massive gap in actually how, in terms of our national strategies towards autism and pregnancy and adulthood. So, and just a couple of slides, just to absolutely visualize how, and using our Ministry of Health language, how the diagnosis of girls is absolutely, how they're disadvantaged compared to boys. That even though we are seeing this greater trend of more and more people being diagnosed across all ages, again, our girls and females are being significantly disadvantaged. And this is something that's going to have implications for our practice as midwives in, the next several years. So you can see that despite the upward trends, we're still not really, between 2020 and 2023, downward trend for our young girls. Sorry, this is a terrible table. It may show up a little bit better when the video's up on YouTube and you can see it in the bigger screen. Terrible color scheme from figure.nz, but basically the yellow is the boys, the green is the girls, and if you can squint, you can definitely, it's quite clear that again, across all the different regions in New Zealand, girls are underdiagnosed significantly more than boys, and sometimes you have regions where no girls are diagnosed whatsoever. So, let's talk a little bit about what my findings were. So a key output within constructivist grounded theory is the construction of a substantive or formal theory. And the emerging theory I came up with is what I call domains of protection. So what are the domains of protection? So domains of protection describe autistic participants' self-determined priorities that guide their decision-making and support seeking behaviors throughout the childbearing period. Participants were really driven to protect either themselves or others in their life. And their domain of choice, or the domain that they often operated in, so to speak, reflected the level of control that they felt and they had in that domain and how they were able to express that. So the domains in question are protection of and by others, protection of the body, and protection of the mind. Protection of and by others describes how participants seek to protect their children and their partners, and sometimes at the expense of their own physical and mental well-being. And it also looks at to whom my autistic participants could and could not turn to for support in trying to do so, or in trying to meet their goals under protection of the mind or protection of the body. Protection of the body, again, concerns those actions and decisions that participants use to protect their body and bodily autonomy. And then finally, protection of the mind explores the same thing, only in the context of how they privilege their mental health or when they would privilege their mental health. Now, these domains are not mutually exclusive or static. Participants kind of chopped and changed between them or reprioritized domains repeatedly, both throughout a pregnancy and also between pregnancies as well. And this often happened when participants experienced a misalignment between their expectations and the reality of what occurred during any point of the pregnancy or postpartum period. That the theory of domains of protection is centered on autistic decision-making is a significant point of difference between this research and some of the ones that already exist that we see published already. The extant literature for autism in general really is very focused on the deficits in autistic cognition and within the niche field of autistic pregnancy and parenthood. The sensory experience of pregnancy has been quite the focal point. And, looking at how these social, sensory, and communication demands of childbearing is often presented as something that autistic people are powerless against, need to persevere through, and find minimal support from healthcare professionals in alleviating. I don't argue with those findings. Many of them, or almost all of them, were echoed in my own. But, and this is the but, my study kind of offers a bit of an alternative, more of a strengths-based outlook on pregnancy. Participants had intrinsic motivations to embrace or even reject decision-making to help them navigate and have control over their experience. That they were able to exercise this power and self-autonomy was made possible in part, I would think, by New Zealand's entire perinatal maternity system. So informed choice, self-determination are enshrined within our midwifery standards of practice, but also New Zealand midwives also kind of have fewer legislative and licensure barriers to, that restrict a lot of their decision-making and where they can birth. So we can provide home birth, we can provide, primary center birth, we have those spaces available. And as well, we also have other things within our maternity system as well, like an NHI system in which, we have an identifier that allows easier transfer of information about an individual between hospitals and between regions. So that's actually something that means that we aren't necessarily carrying a lot of our own healthcare information all the time. And that's a massive administrative burden that autistics don't have in New Zealand. But look, let's take a look at what do these domains actually tell us about the autistic person's journey through childbearing in New Zealand. So protection of the body, as I said, describes decisions regarding bodily and physical health as the participants adapted to emerging complications and challenges to their bodily autonomy. It positions the body as a barrier that protected participants' sensory systems and cognitive functions from external threats. Generally, participants kind of commence that pregnancy with a sense of certainty about their body's capability to birth, especially as a history of high pain tolerance and increased especially as a history of high pain tolerance increased their confidence for success in tolerating labor. Tempering this optimism quite a bit was recognition that there were aspects of pregnancy where they could be vulnerable and not in control. And this is where previous medical trauma and sexual harm meant that participants were under no illusion that the barrier that the body provided could be quite fragile. Having some plan for labor and birth was not taken for granted, and birth plans for people who were within this domain often, but not always, meant that they were planning to birth at home. And this allowed them to exert control over their surroundings. One, by helping them create a positive sensory environment for their baby to be born into, but then also help them proactively mitigate threats. And one of the major threats for this particular cohort was pain relief, or being offered pain relief. Several participants talked about this cascade. They had done that research about the pain relief cascade, but they also shared previous experiences about where analgesia and anesthetics did not work or metabolized too quickly and just came out and just, the system processed it. One interviewee, this experience was so prominent for them that they recalled having difficulty trying to find a midwife who would respect their decision that in an event of a C-section, she did not want an epidural at all. This individual wanted to be under general anesthetic so that she could have that guarantee that she was going to be knocked out. However, protection of the body was limited in the absence of an autism diagnosis to help make sense of the emerging sensory differences that came with pregnancy. Reports of meltdowns and shutdowns during an induction labor or in labor itself were due to the sensory overwhelm from contractions and from the hospital environment. And that kind of meant going into a meltdown or shutdown meant that participants were unable to make sense of what was happening to them, and they were unable to advocate for themselves. As in international research that has already been published, participants from my study in New Zealand also reported that there were incidences where consent was neither given or was unwillingly given for the performing of invasive assessments like our cervical dilation checks, as well as for students to be present in the room. The second point is protection of the mind, or mental health. So in this case, several participants did not see themselves as inherently in control of what their bodies or the medical institutions did during pregnancy and birth. They were also quite wary about making plans or having any expectations regarding pregnancy or birth because their history of meltdowns or shutdowns pre-pregnancy, which they would say was caused by violated expectations or canceled plans, had led to ruptures in very significant relationships for them. And thus that made them very cautious of being unsupported or misunderstood during what they predicted to be quite a vulnerable time for them. Thus, participants who end up prioritizing protecting their mind often proactively minimize the possibility of those meltdowns occurring. One participant did go so far as to forego having a continuity LMC midwife because she was uncertain about the uncertainty around the midwife's availability around labor would have just worsened their anxiety, and that was not a distraction that they needed when they were going to be going into labor. So they took the uncertainty of whoever was going to be at their birth over the uncertainty that an expected person would not be there. However, most other participants were, they talked about how strategic they were in their choices. What they chose to invest in and redirecting their energies into that. Whereas a lot of decisions about birth and pregnancy, they kind of would put towards the midwife. Now we have a popular trope within, a popular stereotype that portrays autistic people as being having an incredible ability to hyper-focus on a task or have restrictive or in-depth knowledge on specific topics. But the resistance in this case to having plans and expectations was to such a degree that participants within the protection of the mind domain often deliberately avoided investing time and research or restricting the flow of information about pregnancy and birth. Instead, they focused on what they thought they could control. That's breastfeeding and preparing for parenthood. And then, as I said, they redirected the decision-making on labor and birth or collecting information about labor and birth to the midwife. Now, this is deliberate imbalance in the midwifery partnership can be, I think, certainly from New Zealand midwives, a little bit surprising because it's a big power shift in our model of care. But for participants, it helped them feel empowered and safe because one, they were reducing the burden on their executive functioning and putting their energy towards things that they enjoyed a little bit more. And secondly, they were giving the tasks to someone who they saw as an expert. So incredible trust in the power and knowledge and the abilities of the midwife. And then finally, looking into protection of and by others. So this is a category that really refers to the social circumstances of my autistic participants, specifically the support they give to others and the support they expect or do not expect to receive. So protection of others kind of explains participant actions, as I said, in terms of safeguarding their families, and protection by others looks at the experiences around the support they could receive in meeting their goals on that. In protection of others, participants were unified in their desire to be good parents. They attended to the emotional and sensory needs of their child from pregnancy to early parenthood. And this intent was exemplified through their efforts to attend antenatal classes, even though they didn't really enjoy it, to adopt public health messaging about breastfeeding, and in their interest in conducting that independent research into parenting methods and practices. However, their capacity to meet their own expectations was often challenged by the emerging sensory sensitivities that would emerge with things like breastfeeding or with parenting, the tactile, the noise. And we see that quite a bit in sort of broader other studies about autistic parenting as well. In protection by others, participants were proactive in seeking support services and asking for help in terms of mental health and parenting at all stages of pregnancy, labor, and postpartum. While the recall of clinical care during this time, as received from doctors, midwives, nurses, was mainly positive, all participants had incidences where they were dismissed and where they were invalidated by healthcare practitioners. One experience that New Zealand autistics share with their overseas counterparts is quite sadly having pain relief delayed or even denied because they either lack the outward expressions of pain or their behavior did not meet caregiver expectations. So particularly if they're in a shutdown mode, they kind of got this flat affect, they're withdrawing, they're not making a noise. So, it's easy to presume that this person, is just coping, or they're just sort of going into it inside a place in their head. No, they could actually be absolutely mentally distressed and not knowing what to do. So that's where, pain relief gets denied or delayed. And that's traumatic. Also, other systematic weaknesses in New Zealand healthcare system are revealed at this time across all perinatal care providers, including specifically the lack of antenatal and postnatal mental health screening and support, and as well as insufficient support with infant feeding issues such as reflux, and particularly what some parents felt were the earliest signs of significant food allergies. Furthermore, complex dynamics within the family of origin and also often smaller social circles of only one or two friends meant that they had a very small support network that really could not fill the gaps left open by our healthcare system. Participants know that protection of the others could not be guaranteed at any point and may also be the forces against which they have to protect themselves or their family. Now, partners, all my participants had male partners. They kind of had an interesting position as both providers and recipients of protection in this domain. Partners were considered as essential advocates and shared in the sensory demands of parenting, and sometimes even taking on those parenting tasks that participants struggled with due to hypersensitivity. So, doing some of the feeding support, holding the baby during breastfeeding, or doing the nappy change. However, over half the participants reported having a neurodivergent spouse as well, and the remainder mentioned that their partners may have had a long-term or historical mental health history. It makes it important to note as practitioners that these partners also have sensory and communication needs, and they too can experience sensory overwhelm at any point during childbearing. Antenatally, this often occurred for participants who were experiencing prolonged nausea and vomiting, and their illness was seen as incredibly distressing for their partner. In labor, the partner's ability to act as an advocate during labor can be impacted if they are watching their partner undergoing significant pain or meltdown or shutdown. And both of those situations are quite influential in subsequent choices or reluctance by that partner to have further children. So we're kind of looking into, we start seeing those trends towards trauma at this point. So what does this mean in terms of the implications for practice? And there's a few, and we'll see how far we get with the time that we have. So connection and continuity. 14 of my participants had a self-employed lead maternity care or midwife who provided continuity of care. But due to changes maybe in participant location or changes in the midwife's practice, only 3 of my 9 multips, or 3 of the 9 multips experienced continuity of midwife between pregnancies. With the exception of 1 participant, continuity of care wasn't really mentioned as a thing that they were looking for in their midwife, or a thing that they were deliberately not choosing for a midwife. Really far more important to them was the, probably far more important to them was the place of birth and, place of birth and midwifery availability. And that usually meant that, but really often the alignment between the midwife and the participant were fine. So the relationship wasn't controversial. But most participants also had a positive relationship with their LMC and found that the clinical care was provided was safe and appropriate. The midwife, as I said, was seen as an expert, and participants were pretty confident following the lead. Few participants did feel that they benefited from the more intensive support of birth planning that a midwife provided, and in many ways, LMCs could be leaders and navigators. And that helped participants gain a clearer insight into what was and wasn't important to them. And they even midwives were even leading participants in creating scripts so that when a midwife wasn't there, the participant, the autistic participant or the autistic client could still actually self-advocate for themselves. And this would help with preventing further traumatization. But nonetheless, participants were pragmatic about their midwifery care, and they were aware that they could be satisfied with their midwife's personal qualities, but they can also acknowledge that maybe care wasn't really to their expectations. However, building connections can equally compensate for when continuity is lost or missing. There's a well-known trait that we autistics often struggle with change, but this wasn't necessarily true. 1 participant rejected continuity of care in labor, but still had a great experience with the hospital-based community midwife. 2 participants experienced a change in LMC midwives in the middle of their pregnancy, but went on to still have positive relationships with their new LMC midwives. And another had, had a completely unknown midwife to attend her birth because both the backup and the LMC were gone. Again, even felt that experience was far better than the one that she would have had with her LMC. And again, you know, similar feeling could occur between pregnancies, as I said, six of my participants had new midwives across multiple pregnancies, and they felt that this care was actually a great opportunity to have even more support than they had in the first pregnancy. Next item, decision-making. Decision-making is a demand. Again, this is kind of an interesting one because we often focus on the sensory. And I think, you know, there's a cascade effect when you give people choice, particularly for autistic people. You know, they want to make sure they're making the right choice. They want to make sure that they're able to do all the results, all the research for decisions. But then that's also coming against their communication and their other needs, like, you know, how much time they need to process that information. Do they need that information in a particular format? And while we could say, oh, we love research, if it's for a topic that's not enjoyable, if it's, you know, particularly like if it's a topic that's forced upon an autistic person, then research becomes stressful, decision-making becomes stressful, and it becomes unenjoyable. This one was more for the New Zealand midwives, the importance of the clinical space. The clinical space, the idea of a really busy waiting room has been shown in international research to be quite detrimental to the accessibility of healthcare for autistics. It's going so far as to being detrimental to actually even people attending a clinic. They will avoid attending, they'll leave a very busy or noisy or sensory overwhelming waiting room. Here, participants in my study were actually like, they loved the clinical space. Maybe they didn't like the palpation, but they said, you know, midwifery offices were clean, they were quiet. There was no one else in the waiting room that they had to talk to. So as we sort of sometimes move to maybe more health model, one-stop shop clinic services where we have the GPs, your midwives, your nurses, and other healthcare services, we may want to think about how can we be adaptive to this cohort that may need a significantly quiet space. Breastfeeding, an unseen impact. Again, breastfeeding is an absolute perennial topic within autism research. And again, my findings agreed with international research in that, yes, the external and internal sensations of breastfeeding were quite intense and sometimes painful. But the unseen impact is what happens when they aren't breastfeeding. So, you know, what sometimes happened for my participants is that they would actually get into some maladaptive disassociation for maybe hours at a time after a breastfeeding period, or they started becoming touch adverse as breastfeeding went on. And a couple of people even said they were touch avoidant for over a year after they ceased breastfeeding. But put this into context, they breastfed. A lot of my participants breastfed for over 12 months, and sometimes some of them even breastfed for 5 years. But there's just need for more of that specific support about breastfeeding and about, you know, more understanding from lactation consultants and peer support about the neurodivergent difference. And then finally, neurodivergent family dynamics, as I said, and between the last slide of talking about protection of others, as well as my slide in the beginning talking about participants, a lot of these families actually belong to very, how can I say it, multiply divergent and disabled households. So it's not just one neurodivergent child, it's multiple neurodivergent adults and multiple neurodivergent children. And a lot of them are going to be undiagnosed when they're under midwifery care. Something to consider again within our practice is that this is something that our participants are dealing with, and what that means is that you know, it's something that's going to come into how they do their family planning. Yeah, so I think, you know, they have to consider what the big decision that they're considering is like, yes, we want more children. However, it's unfair to both, you know, the kind of parent that we want to be for the children that we have who do have significant support needs and disability needs. And also it's unfair to those children themselves to bring in another child, whether that other child is disabled or not. But they also feel very guilty because particularly a lot of these parents have become neurodiversity advocates and autism advocates. So it really touches on a very sensitive point about a lot of things we see about eugenics. They talk about eugenics, talk about curing autism, they talk about can we you know, can we stop, you know, sex select for autism? You know, they feel those questions and that guilt quite keenly. All right, so I've kind of gone over time, but I think the final question is, And the question I want you to take home is, what do you need in terms of tools, information, and resources to provide better care for autistic families? That's me.
Okay, thank you, Bronwyn. For you guys who want to answer the question from Bronwyn, you can drop your question, drop your answer on chat room. And by the way, thank you so much for your presentation, Bronwyn. It was an incredibly insightful and eye-opening presentation. And I
Thank
just
you.
want to share a bit of context from where I come from, Indonesia. In our settings, it's quite uncommon for autistic individuals to get married or go through the childbearing experience. And although it does happen, of course, but currently we don't really have midwife or maternity care provider who specialize or focus on this area. So I found your research really fascinating and important. It's a topic that rarely explored, and especially in Southeast Asia, right? And about exploring the childbearing experience of autistic people in New Zealand really brings attention and to the importance of truly inclusive, respectful, and continuous care. You really help us to see how midwife and healthcare provider can do better, and how much more we still need to listen, learn, and reflect, of course. And now we really love to hear from all of you guys. Let's open the space for some question or comments. But if you have anything you'd like to ask or share, please feel free to raise your hand, unmute yourself, and say your questions. Okay.
I think your comments about, I don't think we need to have necessarily having specialist care in terms of, having somebody who does focus on mental health concerns, neurodiversity concerns. That's lovely. I think it's far more important that we actually, as a whole profession, build our capacity and capabilities in this, because actually, again, so many parents, it's quite a common trope that, and quite a kind of common occurrence that often autistic mothers are diagnosed at the same time as their children or just after. Because that's the instigating effect, because they'll go through the diagnostic process with the children, and they'll start hearing, they'll go through the screening process, and they'll start saying, I did that, I did that, I did that.
Yeah.
So we often, I think we are, we do care for neurodivergent people all the time. They don't know it. We don't know it. So I think we still have a, how do we sort of do a bit more of that connecting without necessarily expanding our scope too much?
Yeah, really. In Indonesia, sometimes the mother just like a denial and not accept that they have autistic. So that's I really agree with Liz that it is like a double-edged sword of continuity that has not registered, right? And yeah, we really need to concern about that. Some in midwife Indonesia should learn from your research, and I will tell her about your research. So maybe we can have another session for this research, because I think it's incredible. For your topic is so amazing. Okay, one question from Sarah. Okay, what are the cultural barriers to accepting neurodivergent individuals' needs during childbirth? Okay, Brian, maybe you can answer the question.
Yeah, I mean, I think
Okay.
we're still kind of working on that intersectional aspect. What does it mean within, we do know that our African American, our Black populations, they're absolutely undersupported and under researched, and underrepresented. Representation is a kind of an issue within autism research in general. But I think we can look into our wider culture, like thinking about what's happening in the US, that there was, there has been sort of this massive advertising campaigns back in the early 2000s that negatively presented autism as this thing that will destroy your family. It means your child can't do this. It means that they're never going to have a normal life. And there's still that barrier for many people that, oh, like, I'm not autistic. I'm not like this nephew. I'm not like this cousin. I can still go to work. So, there are certainly personal boundaries there. In terms of cultural boundaries, sometimes it can be seen that there's some studies by Jill Bevan-Brown that sort of explores a little bit about particularly Maori perspectives about disability. I'm not the person to necessarily speak or represent that, but in some cases it can be an issue that it's seen as a curse. We see that in a few cultures, that having a disability is a curse, but also within the broader Te Ao Maori framework, disability and autism is also accepted as it's a natural difference, and those children are loved just the same. And not just are loved just the same, they're included in the family just the same.
Okay, got it. That's so interesting, right? And because the time is getting off, maybe we can just next to the next questions, right? From Lydia from Ghana. She said, is very educative to know autistic women are going through pregnancy and labor. I will be glad to get some articles to read around their total care during pregnancy, labor, and puerperium. Maybe you can drop your recommendation articles so they can read that for yeah. Okay.
I guess I would say I'll put the link in the chat again for the people who've come in. I do have a podcast that I've done with my colleague called the Neuro Birth Podcast. And on that podcast, for each episode, we do have a list of links that sort of and goes into papers, academic papers as well. That we drew on for our research because we needed to do peer review and we wanted to keep it, evidence-based. So if you look into each episode, we'll have a reference list, and that'll connect you with some research. But I guess I put down Jay Donovan has a thesis and several papers that have come. Donovan, 2017 through to 2023. There's a bunch of papers there.
Okay. In case Lydia did not join in the Zoom from the first, I already share your podcast. So Lydia, thank you for your question and recommendation. You can check the Neurobird podcast by Bronwyn and her team, and you can listen to the podcast. So you can also have some articles from that, right? And yeah, okay, got it. Does everyone want to share her question? Or maybe Bronwyn, maybe you have another insight for us about the childbearing by autistic person?
Do I have any more? Ooh, I guess if you want a final thought, I think it is, the thing for us to consider is the idea of these neurodivergent, multiply neurodivergent family units. And, because it's neurodivergent parents, it's going to be neurodivergent kids. And also there is a previous generation. Most of my participants did identify their own mothers and other members of their family who would also be coming into the birthing suite and support them as neurodivergent as well. So intergenerational. So right now, like the birthing population are getting, because of the care we don't know how to we don't know how to give them, they're coming out kind of traumatized. And so we now have these, and they will come back, and they will be coming back into our birthing suites as the support person, as the grandmother, in about 10 or 20, 5, 10, 20 years in some cases. So we are going to start seeing more and more of these family units of this, and how do we deal with that? How do we deal with multiple generation trauma, intergenerational trauma? But also, as I said, I want to take a strength-based approach. So I want to, I want midwives to realize that, a lot of decisions that are being made by my participants and by autistics, there's a strength there, there's a resilience there, there's a tenacity there that we should be appreciating, acknowledging, and working with as well.
Yeah.